Hello, and welcome to San Antonio Regional Hospital's Community Cardiovascular Lecture Series. I'm Allison Lejean. I'm the Director of Cardiac Services and a registered nurse, and it is my pleasure to welcome you this evening. Tonight, we are going to be discussing peripheral artery disease. But before we begin, I have a few housekeeping items I'd like to go over. If you have a question, please go to the Q&A section and type your question in, and we'll do our best to answer as many questions as possible. If you find that perhaps you have a question that you feel is a little more personal and you would rather not have it read online, my email address will be provided at the end, and I'd be more than happy to get back to you as soon as possible. It is now my pleasure to introduce Dr. Tuan Pham. Dr. Pham graduated with honors from Rush Medical College in Chicago, Illinois. He completed his cardiovascular fellowship at the University of Illinois in Chicago and his interventional cardiology fellowship at William Beaumont Hospital in Royal Oak, Michigan. Dr. Pham is currently serving as the medical director of the Cardiac Catheterization Lab at San Antonio Regional Hospital. Please join me in welcoming Dr. Pham.
Thank you, Allison, for the kind introduction. First, I would like to say hi to our Zoom participant tonight, and I would like to extend a warm welcome to all of you to join our conference tonight. And without further ado, we're going to proceed to discuss about PAD. And the reason I chose the topic on PAD is because this is a very common medical condition as serious medical consequences, yet it's rarely discussed about. So that's the reason I want to choose this topic for our discussion tonight. And let's first start with defining what is PAD. Now, PAD is an acronym for peripheral artery disease. So it's a disease condition that affects the artery. Now, artery is the blood vessel that allow blood to travel from the heart to the organs in our body. And the blood from the heart will deliver oxygen and nutrition to the organ to allow the organ to perform its function. What is peripheral? Peripheral versus central. In the cardiovascular system, central means closer to the center, which is our heart. So anything central is closer to the heart. Anything peripheral is furthest from the heart. In our body, the furthest organs from the heart is our extremity, the limbs. So peripheral artery disease is a disease condition that would affect the artery that connects from the heart to our limbs. So what kind of disease can happen to the blood vessel? We have disease process that involve the artery, mostly caused by deposition of cholesterol into the blood vessel wall. And as time go on, more and more cholesterol will build up. And what you end up with is a bulkier and bulkier cholesterol plaque over time, which will encroach into the lumens of the blood vessel, causing narrowing and restriction of the blood flow. And that would pose significant problem to the organs. In this case, the extremity has muscle that will help us perform work. We perform tasks like exercise, jogging, running, climbing, using our muscle. So if you imagine the restriction in the blood flow basically choke the organ, in this case, the muscle, from receiving oxygen and nutrition, therefore the muscle will struggle. It struggles to perform its work. So if the muscle have to exert, it will fail, the muscle feel weak, the muscle may have pain when it forced to work, and the muscle and the limbs will also be at disadvantage in case of injury that happened and healing process is required. If you don't have enough oxygen and nutrition, that the injury cannot heal. And in other situations, if you have an infection in your limbs, and if you don't have blood supply to bring the immune system, the cell that's respond to infection to the site of infection in your extremity, then the infection will not go away. So those are some of the consequences when the artery that supply blood to the extremity had disease, become blocked, and the blood flow is restricted. Now, we're going to focus tonight mainly about the blood vessels supplying blood to your extremity, but the same disease process also occur in other blood vessels in your body. For example, the blood vessels supplying blood to the heart can also suffer the same disease process. And in future lecture part of the series, I'm sure you will have better understanding about the same disease process that would affect the heart. And also the same disease process can affect the blood vessel supplying blood to the brain, therefore causing event like TIA or stroke. So the blood vessel is important. Disease of the blood vessels is really causing significant problem to our health. Now let's, so now we know what PAD is. How common is this as a problem? Now currently in the US, the population age more than 50, among this population, the odds of having PAD is 1 in 20. And if the population age a little further, age say more than 65, about 1 in 5 Americans will suffer PAD. And if you add on top of the aging factor, other risk factor like diabetes, the odds jump up significantly higher. Say if you over 50 with diabetes, the odds of having PAD is about 1/3, which is very significant. So we talked a little bit about the risk factor there with the aging and the diabetes. What are the other factors that promote the formation of disease of the blood vessel? So here you can see in the list, age is one factor. We already talked about diabetes. Smoking needs to be emphasized a little bit. Smoking is actually the strongest factor that promote peripheral artery disease. The smoker has 4 times the risk of having PAD compared to the general population. And among all the risk factors, smoking is the most modifiable risk factor. One can decide to quit smoking and can get rid of this risk factor quickly. And other than that, you can see here other risk factors mainly involve the chronic medical illnesses that is very common among the population, that's including diabetes, high blood pressure, high cholesterol. And as I kind of implied earlier, arterial disease is a more widespread disease in the entire body. So if someone has disease in the blood vessel, say heart artery or blood vessel to the brain, they are more likely to have disease in the other area, like in the peripheral vessel. So now that we know what PAD is and what the risk factor is, so we know how bad it can compromise our body function. So how do we detect this problem? And so there are different modalities for us to identify and diagnose PAD. But for us in general population, I think we need to really focus on the sign and symptom of PAD. So item number 1, medical history. Item number 2, physical examinations are very helpful for you all to identify PAD. The third item for diagnostic testing is more for physician to help confirm the diagnosis. So we use all three, but for patient perspective, medical history and physical examination is something that you can use. And we're going to spend a little time on those items first. So let's talk about sign and symptom of PAD, something you can easily pick up if you pay attention to your body. And the severity of the symptom or the severity of the sign of PAD is proportional to how restrictive the blood flow become due to obstruction in the blood vessel. So let's say if you have moderate to moderately severe obstruction of the blood vessel, and if you, blood vessel to your leg, for example, and if you get up and walk around and your leg muscle had to perform work, what happened is the muscle will demand more blood supply, oxygen, nutrition to perform the work. Now, if you have a restriction in the blood flow, that cannot happen. So your muscle will continue to perform the work up to a certain point where the muscle cannot handle without the nutrition and the oxygen. Then the muscle will start having pain. So the symptom of pain in the muscle when it performs work, and the pain happens due to lack of blood supply, is called claudication. And claudication is something that you can easily identify. Let's say if you want to walk somewhere to perform certain tasks. For example, if you walk from home out to the mailbox, which is say 100 yards in front of the house, and if you perform that walk and there's no problem, forward and backward to the house, that's fine. But if you take that walk and somewhere along the way, say at 50-yard mark, your legs start feeling weak, you start having cramp and pain, and typically you probably would normally stop and rest until the discomfort resolved, gone away, and then you will continue to walk again. And usually it's very predictable. If you walk 50 yards and you develop pain, you rest, the pain gone away, and you walk another 50 yards, the pain will typically happen again. So if you have pain after walking 50 yards, you typically will be able to reproduce the symptom every time you walk that same distance. So claudication is a very typical symptom that one can pick up. If you have that kind of pattern for your symptom of leg pain and discomfort, you think PAD, because that likely be the reason, okay? Now, symptom is not something that always happen in PAD, mainly because the blockage had to be significant enough to cause the restriction of blood flow to a degree that your muscle had deficient supply of oxygen and nutrition before the symptom happened. If you have PAD, which is milder, maybe had 20% blockage, 30% blockage, 40% blockage, you may not feel any discomfort when you walk. Now, that's when it's moderate to moderately severe, you may feel pain when you walk. Now, if the blockage now proceed over time to become very severe, say 90%, 95%, sometimes 99% block. So what happened is the muscle may then develop pain and discomfort even when not performing work. You know, I guess even when we sit and relax, we do need calorie for that. So when the muscle sit and relax, it needs to be to stay alive. If the blood supply is so restrictive that the minimum requirement of oxygen and nutrition cannot be met, the muscle will have pain. And we have some typical description of a patient that come to the doctor office and complain that every night they go to bed They lay down, and when they lay in bed, the leg will start hurting. And over time, they kind of manage that, and they eventually figure out that if they would have dangled the affected limbs on the side of the bed, the pain would go away. Now, the blood flow is so restricted that adding the effect of gravity is enough to improve the blood flow to the affected limbs enough to relieve the symptom of discomfort. So that's when the obstruction or the restriction in blood flow is so severe. This is where the disease gets into what we call more critical stage. So critical limb ischemia is a condition of part of PAD spectrum when you have hardly any blood flow to the lower extremity, to the limbs. And people will have resting pain, and they typically will over time develop ulcer in the extremity that would not heal. So the ulcer would stay there on the foot or the leg for months, and doesn't matter how they take care of it, it would not go away. And you know, the reason it cannot go away because the lack of oxygen and nutrition, and the demand for oxygen and nutrition for healing process or fighting infection is about 10 times the amount of oxygen and nutrition you need to stay alive. So once you have an ulcer, you know, if you have an ulcer after you have claudication, there is no way that ulcer will ever go away. The only thing that's going to happen to that ulcer is that it might stay the same, or it might get larger, and at some point it might get infected, and that's when a major problem happens. Okay. Now, other sign that we can look at besides the symptom, when you have critical limb ischemia, you can look at the limbs and you can tell immediately. The skin will appear very pale. The color may be dusky. Skin color may be bluish. The leg may be feeling cooler when you touch. And if you compare one side, one limb to the opposite limb, one limb may be cooler. The nail bed may be dry and thickened, poor nail growth. The affected limbs may lose the hair. And so those are the signs that PAD become more severe. Now, the next slide is actually my favorite slide. And let's orienting ourselves to the slide first. There's actually 3 images on this slide. And the one in the middle is just demonstrating the process of PAD. There are 2 short segments of the blood vessels, one below and one above. The blood vessel segment below show you mostly normal vessel wall, except for one area with the islands of cholesterol plaque in there. But there's no significant obstruction. In this early stage of PAD, you will not have any symptom. Everything just very quiet. You won't be able to detect this early stage of PAD. Now, as the disease progresses, and then you build up more cholesterol, and as you can see, the blood vessel above, you have a lot of cholesterol plaque all around the wall of vessel, causing significant narrowing of the vessel lumens, therefore causing a lot of restriction in blood flow. This is when people develop symptom of claudication or pain or discomfort when they ambulate. And if it becomes more severe, people will have pain at rest. Now, the image on the left side depict what we call critical limb ischemia. Now, in the US, at any given time, there's about 2 million people with critical limb ischemia. So you look at this foot here, as you can see, the color is pale. It kind of dusky color, in some areas bluish. For sure, it doesn't look like the normal limbs. And there's a round ulcer at the bottom that's probably been there for weeks and it doesn't heal, doesn't have any sign of infection, but it looked pretty bad. So this is what we call critical limb ischemia. Now, at this stage here, if anyone had this kind of limbs, immediate medical attention is really needed for multiple reasons. I tell you one. First of all, among this, let's say at this point, we have 2 million people with this condition, critical limb ischemia. All right. In the following 12 months of time, 25% of them will die. Think about it. 2 million people in 1 year, 500,000 would die already, right? So this is a serious problem. When you see this, you got to go and have an evaluation. Something is going to be hurting people. 1 out of 4 would die in 1 year. And also, among this population here, a big percentage will end up with amputation, all right? They end up with amputation because this wound failed to heal. And if it's not healing, the physician will have to recommend amputation for the patient. So I want you to remember these 3 images so that we can refer back to them. So in the US now, you have about 10 to 12 million people with PAD, about 2 million at any given time with critical limb ischemia. And every year, 150,000 people will end up requiring amputation. So now we know what it is, how common it is, how much it can hurt people, and how to detect it. So we should talk about how we can manage this problem. Our goal is to detect it early, hopefully do good prevention so you wouldn't have to deal with advanced PAD. And so let's first talk about what is our goal for management of PAD. So the goal is to eliminate pain and discomfort, preserve functional capacity, avoid the need for surgery and invasive procedure, and protect the limb from amputation. Actually, one other important one that we always need to perform is we have to think of that 20% of the people who had critical limb ischemia who would have died 1 year from the time of evaluation. So evaluation of other important vascular system is needed. Most importantly, evaluation of the coronary heart system. The blood vessel that supply blood to the heart may be affected, may be severely affected, and people may be at risk for heart attack and sudden death from that. So not just evaluating for PAD, people also need evaluation for their heart, evaluation to make sure they don't have risk for stroke. So let's go over the quick general options of management and treatment for PAD. Here we have 5 items, including simple strategy at early stage, lifestyle changes, medication, wound care, invasive revascularization procedure. That's including traditional open surgical bypass and minimally invasive endovascular intervention. And hopefully item number 5 is something we can avoid, and that's amputation. So we're going to focus first on item 1 and 2, where we can hopefully prevent problem from developing. And we manage in early stage so you don't have to deal with something so significant like surgery and amputation. Now, lifestyle changes mainly address the risk factor, all right? So risk factor here, the most modifiable one we spoke about is smoking. So smoking cessation is something that can be done, and there's multiple support system that can help you to achieve the goal. This is not easy task, probably one of the most difficult things to do for most people. So you have counseling that can help you. You have nicotine replacement therapy that can help you. And we have other medication that can make the process easier for you. Besides smoking cessation, we also recommend healthier diet with low salt, low cholesterol, low carbohydrate content, mainly to address risk factors like blood pressure, high cholesterol, and diabetes. And the third item is very important. Walk-in program. This is very beneficial for people with moderately severe restriction in the blood supply to the leg that cause them pain when they ambulate. Walk-in can improve the total walking distance as well as the pain-free walking distance if you follow strictly with a program. So you can really achieve improvement, and there's reason for that. Here at San Antonio Regional Hospital, we do have a rehab program that's structured to provide supervised walking exercise for patients that have claudication. And beyond the lifestyle changes, we also had option of using medication to prevent and treat PAD. Medication here mainly to modify the risk factor. You really need to work with your doctor to tailor a good medical regimen for you that fit you the best. And it depends if you have diabetes and not high blood pressure or high cholesterol, not diabetes. It's all depends on multiple factors that your doctor can pick and choose which medication regimen will be best for you. There's certain medication that are that have extra benefit for PAD that your doctor may place you on. For example, there's medication also that treat high blood pressure, but also improve the function of the blood vessel that your doctor can place you on. Now, besides the medication for risk factor, you have medication also to relieve symptom of claudication that your doctor may prescribe for you to make to improve your quality of life and decrease pain and discomfort. All right. Now, in addition, patients with PADs frequently will be recommended to be on antiplatelet therapy. These blood thinners such as aspirin, Plavix, and other newer ones are there and prescribed for you to prevent acute clot formation that may cause complete occlusion of the blood vessels and acutely stopping the blood flow to the limbs. And other medication here on the list is antibiotics in case the ulcer got infected. Now, those treatment and management options are for patients that have early stages of PAD. Now, if you unfortunately get to critical lymph ischemia, where you have an open sore that won't heal, the treatment is a little bit more aggressive. Here, you definitely will need podiatry care to take care of your wound, clean the wound, look after the wound, make sure it's not infected. Because once the wound infected, it usually progresses to amputation very quickly. Now, when people get to critical lymph ischemia stage, the risk of amputation is so high that people should really have vascular evaluation. So you need to have evaluation of the blood vessel so you understand exactly where the obstruction is. And we can do this with multiple modality. We can do this with ultrasound, which is my personal favorite. You can image the blood vessel, know exactly where the cholesterol plaque is built up, and you can evaluate the severity of the obstruction. So it's safe, it's easy to perform, it's painless, and it's harmless. So absolute favorite here. Other modality you can perform and readily available, including CT scan or MRI with contrast agent. So you can take anatomical picture of the blood vessel. And then The last imaging modality is invasive angiogram. We usually reserve this option for patients that we intend to provide endovascular intervention at the time of angiogram performance. So revascularization procedure in the past for a long time, mostly surgical, open surgical bypass. And the surgeon will put a bypass graft connected to a normal blood vessel upstream from the obstruction, and then connect the other ends of the graft to a normal segment of blood vessel downstream from the obstruction. So when the bloods go down and hit the obstruction, it will travel in the bypass graft and go down distally and basically bypass the obstruction. The newer, more recent advancement is minimally invasive intervention. And what we do here is everything performed through a larger IV, we call a sheet, which is about 1/10 of an inch. So we put the sheet into the blood vessels. And after we inject the X-ray dye and do angiogram, taking picture and know where the obstruction is, once you identify the obstruction, we can then proceed with the intervention procedure right then and there. So we take one of these specialized thin wire down to the obstruction, and we would advance the wire across the occlusion site. And then over this wire, we have these small tubing that's kind of, we threaded on the wire. The tubing here is really thin, and it carried the balloon on the tip of it. And then we advance it on the wire as a rail. We got the balloon to go into the area with the obstruction. Once the balloon inflated, the balloon will stretch the obstruction to open it. And we have another balloon, similar balloon that carry a stent on it, which is a slotted metal tube. It's crimped onto the balloon, and the same process can be done. You take the tube down and deliver the stent to the area with the obstruction. As the balloon inflated, the stent, the metal stent, get expanded up against the artery wall, and the stent stay there to hold it unblocked. So now once that's done, the wire is removed, the sheet or the IV is removed, and patient will be monitored for a few hours before they can go home. So the procedure is done. It takes maybe 2 hours to do, depending on how complex the obstruction is. And then after procedure done, we monitor patient for 2-3 hours, and then patient go home safely. So this procedure is done more and more over time because it's less invasive and easier for patient to recover afterward. And of course, other option here is amputation, which is exactly something we don't want. It's an option for basically all therapy, the failure of all therapy. So that's actually an adverse outcome that we want to prevent. So let's go back to this slide, favorite slide again. So why is it, what is it that make people end up with leg amputation, right? So here, look at that foot on the left side of the screen. We have an open sore. And why is it that open sore doesn't go away? We talk about vascular deficiency, right? We don't have enough oxygen supply and nutrition supply for the ulcer to heal. What else can happen? Well, frequently, patients with this condition had other conditions like diabetes that cause a complication called peripheral neuropathy. And you believe that this patient here may walk on this foot for days and weeks without feeling any discomfort. And it's amazing that actually happened. I had one of my personal patients who walked around and step on one of the nails that go through the shoe, through his entire foot, and walk on it for hours. He didn't know that the nail was there until he got home and took out his shoe. So neuropathy compromised the ability to detect problem. So people would have this, sometimes never look at the feet, and have this for days and weeks. So podiatry care is needed. Patient may have neuropathy, never detected, have poor blood supply, doesn't really reach out for care, so they don't have podiatry care to watch the wound, to make sure there's no infection, to maybe refer them for vascular evaluation. And patient may not have treatment in case they have wound infection. So these are items we just covered. Poor healing due to decreased blood supply, lack access to care, podiatry care, they keep walking on the affected limbs and cause worsening of the wound and maybe get infection. And when it gets infection and if the infection becomes severe, then amputation is recommended. So let's talk about the current indication for amputation. There are two major categories of indication. The one that's still accepted and reasonable and logical is for patients that suffer severe trauma when their limbs is so severely injured or disfigured that they cannot be repaired, or if they have severe bleeding, severe infection, then those limbs had to be amputated. But the other category of amputation indication is, as you see on item number 2 on your slide there, chronic non-healing ulcer. All right, that's what we see with PAD. And it's still in many places in the country, this is still a standard accepted indication for leg amputation, which I think will become less and less accepted in today's standard. And item number 3 is just when that ulcer become infected. Now, look at item number 5. The only one contraindication for amputation is vascular insufficiency. And why? If you don't have enough blood supply to the surgical site, then that surgical site will also not healing. So if you have no blood, you have deficient blood supply, then that is a contraindication for amputation. That's kind of odd. Personally, I think vascular insufficiency should be contraindication for surgical amputation, mainly because if you can eliminate the vascular insufficiency, this chronic non-healing ulcer would heal and you would not need a surgical amputation. So let's look at that standard of care in the past. This is the data from Medicare. And as you can see, in the past, among all these 20,000 patients that underwent limb amputation, right? Only 17% of them had vascular evaluation with angiogram. That's shocking. I mean, as much as a reversible cause of non-healing ulcers, but nothing really was done, significantly done for that in the past. And then less than 50% of people even have any attempted surgical intervention. Well, the good news is that is changing over time. Okay, as you look at this slides here, it demonstrated really well. This is data from a single big center over 12 years. And this orange bar here show you the percentage of surgical revascularization being performed at different time interval there. And you can see surgical percentage of surgical bypass go down over time, right? From 1999, there was 100%, 2004 was 67%, and in 2010, that was 11%, all right? And then look at the green bar over time. The green bar represents the rate, the percentage of endovascular intervention procedure. And as you can see, back in 1999, none of the revascularization were done using this technique at all. And in 2004, you start to have it utilized more. and it's increased up to 33%. And by 2010, it's now 89%. And with the change, right, increased utilization of endovascular intervention, you see that the rate of amputation go down also. So you start with 32% in 1999, it go down to 20% in 2004, and by 2010, it was only 5.2%. You know, my personal experience is that it's actually even lower than this, 5%. So here's some of the example case that we, to demonstrate what we talk about as far as endovascular intervention, and talk about the patient and the risks and things like that, put everything together here. So this slide for a gentleman, 65 years of age, 65-year male with diabetes, high blood pressure, high cholesterol, and current smoking. He had this toe here. You see the third image of the slides. You got the infected toes. It looked bluish, dusky color. It looked like it need to be amputated. So actually the physician were doing a good job. Before he do amputation, he sent the patient for angiogram to perform vascular evaluation. And the first image on the slide here, you can see in the oval circle, you see the blood vessel is coming down and it's abruptly stopped. And that is at above the right knee level there. And so the patient, the treating physician then proceed with endovascular intervention. So he took a guide wire, go through the obstruction, and then he performed a procedure that we also perform called orbital atherectomy to shave the calcium and the plaque within the blood vessels, and follow that with balloon angioplasty. Now, after that is done, the blood flow reestablished. And a few weeks later, the toe is healed. You can see the last pictures on the slide there. So the patient didn't have to have amputation, okay? So that demonstrated endovascular intervention. But I think one important thing to point out here is this. Let's say if this patient would have proceeded to have the toe amputation without the knowledge of his vascular system, right? What is the odds of the surgical site going to heal after that toe amputation? Probably nil, all right? So this patient could have undergo toe amputation and the wound would not heal, and maybe go for midfoot amputation, and definitely that would not heal. And may undergo below the knee amputation, and that may not heal either. If you would have do that, you have to go above the knee for this limb to be, for the surgical site to heal. That's where the blood flow was present. So I think now in current standard, no one should have amputation without knowledge about their vascular system. And this is a patient at our institution here. And this gentleman is 61-year-old with multiple risk factors, including diabetes, hyperlipidemia, hypertension, and he did have coronary artery disease. He actually did have bypass surgery because of the severe coronary artery disease. So he had this critical limb ischemia, and he had to have partial foot amputation. You can see the third, fourth, and fifth toes were amputated. Part of the foot was amputated, and he got wound that had to be cleaned and stitched back, the skin stitched back together. But his wound burst open because he had insufficient blood supply. The tissue cannot heal, and then the swelling happened, and the suture broke, and the wound opened again. So the patient will refer to me, and as you can see here on the second image of the slide, there's so many little branches of the blood vessel, which mostly stop at the ankle level there. You can see the ankle joint in the bottom third of the screen. All the blood vessels that go down to that level stop. Now, We proceed to perform angioplasty for these blood vessels here. We pass the wire, like we said, across all these occlusion, perform balloon angioplasty. We reestablish a nice lumens with excellent blood flow. And a few weeks later, his wound healed almost completely and ultimately healed, but I don't have the completely healed picture. So that demonstrates that a couple of things. One is the ability of angioplasty, endovascular intervention to heal wound to prevent amputation is excellent. In a case like this, there is no way that you can bypass anything because the blood vessel is so small, the tissue is not anywhere you can put a small bypass to. So in case like this, bypass cannot be done, okay? And if we don't have the option of angioplasty, this patient for sure will end up with amputation, no question about it. And this is another patient in our institution here we took care of. This is a 62-year-old lady, past history of tobacco use and history of stroke. She came to the hospital after several days of severe pain in both feet. And you can see the first picture of the slide, both of the feet mostly gangrene, the tissue died. And so she was appropriately recommended to have amputation of both of her legs just below the knee level. This young lady totally refused, and I can understand why, but she totally refused. So I was asked to provide some alternative treatment option. So we took care of her. We take picture of the blood vessels. It turned out that she had occlusion of all the blood vessel from the ankle toward the toe in both feet. And she had a process of blood clot. This lady likely has mild or asymptomatic COVID infection, and it caused this complication of thrombosis in both feet. And so we treated her with blood thinner for several weeks. And she came back and the blood vessels completely opened up, but it's only open just to the point of the gangrenous tissue, because when it's gangrenous, the blood vessel also gangrenous. There's no way that the blood vessel can come back. But anyhow, it's open enough that our podiatrists were able to do partial foot amputation on both sides. And today she almost completely healed. This is about 3 months later. So she's very happy. So with that, we're gonna wrap up our presentation for tonight. And you know, we would like to say thank you to San Antonio Regional Hospital, all of our supportive staff for being so kind and putting your time and effort to make this possible and to help our community. So thank you so much. And I'd like to turn our attention to Allison for our question from our participant.
Thank you so much, Dr. Pham, for that very informative lecture. We really appreciate that information. We do have a few questions. One question states, I feel good, but I'm over 65. What kind of screening would you recommend? What are the risks of the screening? And how often would I need to be screened?
Great question. You know, I think you talk about trying to do things as early as you can, which is the best approach for any of this at all. And you're not talking about PAD. You also talk about coronary artery disease. You also talk about cerebral vascular disease, any of these blood vessels that may have problem. And you look at the statistic and you know that when you have more than one risk factor, all right? If you're more than 65, do you have tobacco use? Do you have diabetes? Do you have this and that? So all of these factors will increase the odds that someone would have disease of the blood vessel. So you kind of know your risk in a way, or your doctor can help you evaluate your risk. And once you establish your risk, then you know how aggressive you need to be with prevention, right? So if your risk is high, you need to focus a lot more on on prevention. So what other thing you can do with prevention? As I talked about earlier, you need to address all of the risk factors, right? If you feel well, but you don't want to have future problems. If you smoke, you stop smoking. If you have high blood pressure, you stick to your low salt diet and you take medication if you need to. Same with diabetes, you have good diet, take medication, do what your primary doctor recommended, and cholesterol the same. So all of these risk factors that you can modify, you modify them to the best. And then that's the best that you can do. And if you can just do prevention perfectly well, I can almost assure you that you would never have to deal with multiple other bigger problems.
Thank you very much. Is there any way to get rid of the existing cholesterol in my arteries? And if so, how?
Well, that's a great question. You know, a lot of time that's actually question come up a lot in the past. So it's all depend on how bulky the cholesterol plaque is. All right. If it's just a small plaque, it does not cause any restriction of the blood flow. All right. So what you want to do to that particular plaque is to try to make it stay the same. That means as long as it doesn't get worse, then you would not have any complication from it. Now, if the plaque got worse, then it caused lumen obstruction, blood flow restriction, and consequences, and that become a problem. But if the plaque is small and you modify your risk factor, you attack the blood pressure, the cholesterol, the diabetes, the smoking, then that plaque likely will stay unchanged. Now, if you have bigger, bulkier plaque that cause significant obstruction, that cause you leg pain, that cause you non-healing sore, then you go with the path of definitive evaluation of the vascular system. You may require intervention. So that's what I would do. But in general, if the plaque is so bulky that cause severe restriction, yes, we have techniques that we can remove them with the device that I mentioned. It worked like a roto-rooter. It shaped these and grind them into microscopic particles, and it's cleared out by your body. We can do stenting. So there's multiple things we can do.
Thank you. If I quit smoking, does that reverse a PAD, or am I forever keeping the same amount of blockage?
If you modify, not just stop the smoking, if you control the diabetes, the blood pressure, the cholesterol, you've done all the prevention really well, it is unlikely if you can significantly change the existing plaque volume. So whatever you build up to that point typically does not go away. And if it does, at very, very minimal amount, and it's insignificant. Now, that brings to another point. So that the important message is this, that you really do not to remove the cholesterol plaque. You really don't. What you need to focus on doing with risk factor modification is two things. One is to make the plaque stay and not getting worse. And two, in some blood vessels, like the one to your heart, you want to convert the cholesterol plaque from something called unstable plaque over to something called stable plaque. Because the unstable plaque are the one that can rupture, it can then cause blood clot formation. That can cause the blockage to go from, say, 50% to 100% within minutes. So the key is not to remove or reduce the plaque too much. The key is to make sure it doesn't get worse. And the key is to make sure it's stabilized with treatment.
Thank you. If I get leg cramps at night, is that a sign that I have PAD?
The answer is no, very unlikely. Like I described earlier, the symptom from PAD tend to be persistent, right? Very reproducible. If the blockage is moderate or moderately severe, and you make the muscle work, that's when the muscle, because the lack of oxygen and nutrition, you basically make the muscle work while choking the muscle. And so that's when the muscle hurts. Now, when the obstruction is critical, then you typically would have pain all the time, all the time. It doesn't have to be at night. It can be in the day, and the pain will be there. So it won't be episodic, like leg cramp type situation. So that the answer is no.
Thank you. Can an angioplasty cure PAD? And if a stent is placed, how often can you place a stent?
You know, PAD to cure PAD. That's a great question, I think. The stent is not intended to cure PAD. The stent and the angioplasty and atherectomy device are intended to reestablish the blood flow. That means we just clear the blockage or the obstruction within the lumen of the blood vessel so that the blood can flow past that and supply blood to the muscle to perform work, to the wound, to heal the wound, to the infection site, to fight infection. So the stent is not really intended to cure. It intended to treat the consequence of the disease. You really, the way, I don't know if you can call it cure, but you treat all of the risk factor really well. I think that is as good as curing it. That means if you have a condition that you can do something to stop it completely from hurting you, I think that should be qualified as curing. So the way you cure PAD, then to start early, start with prevention, lifestyle changes, medication, modify the risk factor, and exercise. That's what I would do.
And our last question for the evening is, what are some of the latest technologies that are available at SAR for the treatment of PAD?
You know, there's a full range of technology that we can use to treat PAD, to perform endovascular intervention. Over the years, we developed the most basic one is balloon angioplasty. So you take the balloon to the area with the obstruction and inflate the balloon. And we spoke about the stent. We mentioned a little bit about the atherectomy device. So the device is like a rotor-rooter. It had the olive structure at the tip of it, and that coated with diamond chip, and it spin 50,000 RPM and just shape all this calcium and plaque into small particles. And we have other, in the past, we also used radiation therapy in case the blockage came back. We have balloon that coated with medication that prevent plaque from building or from recurring. We have stent that coated with medicine to prevent plaque from rebuilding to obstruct the blood vessel. And then we have other balloon that can perform like lithotripsy kind of ultrasound to break up the calcium in the blood vessels. And then that allows you to place the stent. And then there's research devices and techniques that allow you to perform treatment or even perform percutaneous bypass procedure to treat these severe obstruction. And that's still under a lot of research. But in the future, I can imagine that anything that can be done to treat these blood vessels can be done with just an IV in the blood vessels.
Well, thank you again, Dr. Pham, for that very informative lecture. And we'd like to thank all of you for joining us this evening. We're happy you were able to be here, and we hope you are able to join us again next week as we continue our cardiovascular community lecture series. Thanks a lot. Have a great night.